So it's my pleasure to introduce our first speaker, Dr. Lily Chan. Dr. Chan is Associate Professor of Medicine in the Division of Nephrology, Division of Data-Driven Medicine, and Institute of Personalized Medicine at the Icahn School of Medicine at Mount Sinai, New York. Dr. Chan cares for patients with a variety of renal conditions ranging from acute kidney injury to end-stage renal disease. In addition to patient care, she is an NIH-funded researcher with a focus on examining and identifying methods, including the use of machine learning and natural language processing to improve outcomes in patients with kidney disease by evaluating unmet social needs and interventions to address structural racism in the care of patients with kidney disease. So please help me welcome Dr. Lily Chan.
So thank you everybody for staying for the 4:30 session on Saturday. I'm sure you guys are dying to get out of here and party it up. But also thank you to the steering committee for putting the session together and inviting me to be one of the speakers. So this session is divided into two talks. I'm going to focus mostly on the generative AI, NLP, and LLM section, while Dr. Tangri will work more on the machine learning diagnosis and prediction side. So I have following disclosures. I do have funding from the NIH, and I am a consultant for Vifor Pharma, but they are unrelated to any of the topics we're talking about today. So the first thing we're going to do to start off with is I want to ask everybody, how often do you use AI? Less than once a week, a couple times a day, or daily? And it's a Slido, so I'll give everyone a chance to fill it out. So this is really great, and I love kind of seeing this little race between daily versus less than once a week, which are kind of going back and forth between what's number one. But it does seem that most people are using it on a daily basis, but it's like the polls, right? Almost every day, and then really just almost never. And I wanted to argue that AI is everywhere, and we're probably using it even when we don't realize we're using it. And I note my question was not about AI in healthcare, it was just AI in general. So if you used Google Maps to look up, like, how long would it take me to get from the airport to the Sheraton Hotel where I'm staying? And you're looking at the time estimates and the different routes, right? That's an example of AI. If you're shopping on Amazon and you're looking at any of those customer reviews, you now notice that you don't have to look through each individual review. You can just look at the AI summary, and that it gives you a pretty nice overview of all of the thousands of reviews so that you yourself don't have to look through it. And if you have used Google Translate when you're traveling abroad to another country, that's another example of AI. And I use these really almost every day, if not more than once a day. And so the learning objectives of the talk today is to give an overview of what NLP and LLMs are, talk about how these are getting used in clinical care, and just ending with a little bit of caution about the use of AI. And so because it's about integration into clinical care, I really wanted to be, let's follow kind of with a case through it. So you're seeing there's a person who is 54 years old. She's a woman. She has a history of hypertension and diabetes. And she recently saw her PCP for just a flu-like illness. They did some blood work. She hasn't seen a PCP in a while, and she found that her creatinine was 1.9. And so a person who really hasn't been in touch with healthcare and is not sure what to do now. So what does all of our patients do, or many of our patients do? Ask Dr. Google, exactly. And if you notice, and if you've used Google recently, they've also now integrated these large language models and AI into their responses. This is based off of Gemini. And so it gives you an answer. It could be normal for someone with one kidney. Well, now she's like, well, do I have one kidney? Do I have two kidneys? Like, I don't know. And there's all these things, and it's like really concerning, and now she's really, really scared, right? But let's go into, like, how are these AI algorithms really doing this? So I threw out some acronyms already. What is NLP and what is LLM? So NLP is natural language processing, and it's just an area of AI where you're having a machine comprehend, analyze, and work with human knowledge, specifically language. And it's really useful for finding specific things and really focused tasks, such as named entity recognition. It's meaning like you're looking for a specific disease within an electronic health record. It's really good at these really small tasks. While LLMs, which are large language models, it's actually a subdivision of natural language processing. It's focused more on generation of text and summarization rather than identifying, although it can still be used for that. And so I guess, remember the squares versus rectangles, kind of similar. Like all large language models kind of fall under NLP, but not all NLP are LLMs. So. And there's multiple reviews now. I found this one nice picture that kind of talked about the different uses of NLP and LLMs, not just for us as medical professionals, but also for patients. So things like helping with documentation, suggesting, actually reviewing the case and actually coming up with a differential diagnosis and potential treatment plans. And then for the patient side, it's like tracking different symptoms, answering some questions, helping them understand their lab results, and interpreting physician notes, which may contain a lot of medical jargon, and actually having a computer kind of break down that information for them. And so I wanted to give you one example of how we've used NLP within our own research. So we looked at identifying symptoms in patients on hemodialysis. So we interviewed 97 different patients from our standalone dialysis unit. They had to be over the age of 18, be on dialysis for over 30 days, answering surveys with minimal help, and on dialysis 3 times a week. They completed a modified dialysis symptom index, which was 21 different symptoms. And what we did find is in the blue bar, we had the patient survey. So if this person answered yes to the symptom at any point over a 1-month period, and we interviewed them every dialysis session for 1 month. And we also asked their nurses, which is the gray bar, their physicians, which is in the pink bar. And then here in this tiny little slither of yellow is when we asked our computer to read through all of the notes for the month before, the month of, and the month after the patient was enrolled in the study to see whether or not there was documentation of these symptoms that the patients were reporting. So what you can see is that there's a drop-off between what patients are experiencing and reporting, what the providers are recognizing, and they recognize much more, though, than what's actually ending up into the documentation. And we also kind of tested the algorithm to see, well, if we compare it to manual review, how does it perform, versus when we compare it to the patient surveys, how does it perform? And what you can see is that overall, these test metrics for these algorithms were really good compared to manual review. So if it's really there, it's documented, it's true, but a lot of it just doesn't end up getting documented. So this was is recently published in January. So this is an example of how you can use NLP to kind of advance patient outcomes research or patient care. So how do we actually do this? There's a lot of different NLP pipelines, but all of them essentially have to do, you get all of the free text from the electronic health record or whatever it is that you're looking to do, and it has to do all of this processing of this notes, spelling correction, because we're not all great typers, and then also breaking down, similar words like runs, running into the similar words so they can be understood. And then you're going to actually be able to use the algorithms to process those notes. But what I really want to emphasize is that these computers do not actually understand words. They understand numbers. So what they're essentially doing, what we have to do is convert language into numbers so that we can analyze them. And so some simple approaches, probably the most simple and one of the earliest is called bag of words. And what it is you're developing this number, and it's simply a count of whether or not the word is used in the sentence. So in this sentence, I like oranges, do you like oranges? Apples does not exist in the sentence, but oranges does exist twice. So the text vector or the numerical representation of this sentence is simply 011221. You can see that this is super simplistic because it doesn't account for the meaning of the words in any way. It's simply a count. And so more advanced ways of converting this language into words now do exist. Word2Vec has been a very popular one. It's a neural network that is used to represent the words such that words that are closer together are more similar, while words that are farther apart are less similar. So a businessman versus a businesswoman is further apart than a businesswoman is to waitress. And these, again, are just the representation of the words in a two-dimensional space. So it's that this whatever 0.15 and minus 0.15 is how you would represent businessmen as a numerical representation. The problem with this is that English language is complex. One word in English can have multiple meanings, and this does not account for that. So once it's there, regardless of how you're using that word, it is going to be the same number. So more advanced algorithms for embedding have now exist. One is called BERT. It's probably one of the earliest transformer models. A lot of different versions of this now. Clinical BERT, a stigma BERT, so there's different versions, Roberta, and they're kind of all trained on either slightly different versions of text, more for medical literature, more to identify stigmatizing language. And what this is that it's actually able to represent the word using multiple types of embeddings and not just one specific number. And this is possible because of transformers. And I'm sure you are all transformers has really changed the field by quite a bit. And the seminal paper about transformers is this paper that was put out by Google. Attention is all you need. And this is the technology that is behind ChatGPT, Gemini, and Meta's Llama. So what is attention and why do we need it? So let's say, for example, going back to our Word2Vec, and we're trying to just represent these words in a two-dimensional space, and the words that are similar are grouped together. If the further apart they are, the less similar they are. On the bottom left, you have leaves, flowers, and twigs. On the top right, you have meow, moo, chirp. So let's think about bark. Who thinks, show of hands, who thinks that bark should be on the bottom left? Who thinks on the top right? Who thinks it depends? I see some. Exactly, it depends how you use it. So the tree bark is brown versus the dog's bark is loud. And so how do you represent that? And the way attention works is that it allows the numerical representation to adjust the numbers in regards to the words around it. And that's kind of what attention is, such that if it's in the context of the tree, it moves to the bottom left. If it's on the context of the dog, it moves to the top right. And that is what the transformer technology really is built on. There's this multi-head attention, both in the inputs and on the output side, and just really emphasizing that the LLMs or these models and transformers, again, are not understanding the language. They're statistical distribution of the words, and it's guessing based off of the words in the sentence before what the next word should be using numbers. So the first person to walk on the moon was, and it's taking that into context and outputting Neil Armstrong. So back to our case. Patients now extremely scared what they read on Google, Dr. Google's AI summary, and immediately uses a chatbot to book an appointment to see you in the clinic. And so I'm sure you've kind of used chatbots at some point, or you see the chatbots on the bottom of the help screens. And so a lot of them originally were built on what we call rule-based, meaning that they have very specific and coined answers based off of the questions and limited functionality. But a lot of these chatbots now are based off of this LLM technology. So they're a lot more flexible, and there's a lot more that they can do and also help answer and understand the language. So patient comes to see you in the clinic, you're seeing them. You do a very thorough H&P, you repeat the blood test, you order a renal bladder ultrasound, you get a urinalysis. The patient goes home and we'll see you again in 4 weeks. You've seen them for 15 minutes, you've ordered all the tests, now you're gonna spend the next 15 to 30 minutes documenting, right? So has anyone noticed that I secretly snuck in this little cell phone down here on the bottom? Well, that's your AI scribe. So has anyone used AI scribes in their clinic? Raise a hand. All right, so it's a minority. It's similar to what I was at another conference last month, and it's also about a couple people who are using them. Most people have told me that they really like it, but I, myself, we don't have it deployed yet. But what are AI scribes? So most of the ones I did see when I did a search for them they're based off of a smartphone. They're actually listening to the entire conversation to both the patient side and the physician side. But it's not a simple word-to-word transcription. It's actually digesting what's being said and formatting it into the appropriate note template that you're telling it to do. So that it can summarize in the HPI, the physical exam, and also your plan. Some of them are integrated into the electronic health record. So this specific product, I have no stock in this, and I do not advocate for any specific one, but this one is integrated into Epic so that you can very quickly just have it there and it'll write your note for you. And so there was one study out of the Kaiser Permanente group, and they started with a 2-week pilot in 47 physicians. They then, based off of the really positive feedback from that pilot, decided to get 10,000 licenses and give it to all of their providers over the course from October to December. And all the training that was done was a 1-hour webinar. And then they looked the device was actually on their smartphones, recorded, and uploaded into a secure cloud server. So over 10 weeks of implementation, about 3,000 out of 10,000 providers did use the tool, and you can see that about a month in, it kind of reached plateau. So people who were going to use it were using it, but those who did use it continue to use it, and the number of encounters they were using it for continued to grow throughout their monitoring. So they looked at a couple metrics. One was they were all metrics that they could use to look at through the EHR. So charting time, how much time were people writing notes outside of the office hours, writing notes on non-scheduled days, and outside of the 8 to 7 p.m. And they also looked at the time per note, time in orders per appointment. And what they did find was that there were significantly larger decreases in time spent in the electronic health record outside of 7 a.m. to 7 p.m. among users versus non-users, and time in notes per appointment was also lower in people who used the AI scribe versus who didn't. They also manually reviewed 35 examples of the AI-generated notes, and overall they then scored the transcript, and they did find that all of the metrics that they were evaluating for, such as bias, internal consistency, and whether it was succinct, organized, and accurate, were very, very high, all above 4.6 on a 5 scale. All right, so going back to our case, you now have the results of the urine study. There's no blood, but there's 3+ protein. There's protein to creatinine ratio is 4. Hemoglobin is 9.2, platelets 200, BUN is 30. Creatinine went from 1 point now it's 2.3. Now, the patient does have diabetes, but is this diabetic nephropathy, or is it something else because she's got nephrotic range proteinuria? So you call the patient, you're like, okay, we need to figure this out. I want to send you for a biopsy. And the patient's like, well, what is a kidney biopsy? Can you send me some information? So me as a provider, I'm going to pull out my handy dandy ChatGPT, and I'm going to ask it, what are the risks of a kidney biopsy? And so I want you all to take a minute to read the text and tell me what you think of it. Do you hate it? It's okay. Neutral, like it, love it. I'm just going to go to the Slido side so people can get the QR code, and then I'm going to go back to the response, and we want to see what people think. Okay. All right, so this was I think everyone got the QR code, but this was what ChatGPT told me. So I'll give it about another 30 seconds, and then we'll look. I think everyone may have answered already, so it's okay. So I thought it was okay also. My issues were, well, It doesn't really explain why we want to do a kidney biopsy. It doesn't explain it in a plain language way. Hematoma is like really like, oh, I don't know what a hematoma is. That sounds really scary. So what can we do? So what if instead I change the way I ask ChatGPT and I say, well, I'm a nephrologist and I want to provide information regarding the risks and benefits of a kidney biopsy to a patient. Can you make it very patient friendly? So now I think it's a lot better. Hopefully you guys kind of agree. And it says, okay, well, you could have mild bleeding, you could have larger bleeding, there could be all of these things, but it gives it in a much nicer, plain language way. So patient goes for, she's like, okay, this sounds reasonable, let's do the biopsy. And the pathologist, your institution doesn't have a nephropathologist on staff, but they partner with a company, and that's actually an AI company that is actually able to read the kidney pathologist slides for you. And this actually has a huge area of AI research, just the nephropathology side. There are a couple companies that I did find. Most of them seem to be focused on the research side and not yet on the clinical side. But these are examples of what these AI tools can do. It's that they're, instead of looking at a specific segment, they can do the entire slide to get it digitized and then processed. And it can segment the kidney, it can identify all of the structures. This is the glomerulus, this is the tubules of the entire slide, not just the section that the pathologist is looking at. It can also give you some of the pathological changes, so things like glomerulosclerosis or interstitial fibrosis. And based off of what they're finding, if there's a lot of interstitial fibrosis, it can even be used to predict these changes in EGFR or to compare the morphological changes of, let's say, people who have lupus versus people who have IgA. So you can do these much larger comparisons than having to have a human go through it. So going back to the case, unfortunately, the patient, now we're skipping forward 2 years. The patient has progressed to chronic kidney disease stage 5. They elected to start on in-center hemodialysis. Since starting on dialysis, this patient has had trouble controlling her potassium and phosphorus, and she's asking you, give her some recipes or give her some ideas of how to control it. So I want everyone to do this exercise. If you haven't used any of these large language models before, you can just scan the QR code, it'll take you straight to one, or you can use your favorite large language model. If you're used to ChatGPT and you haven't used any of the other ones, I also suggest you can try a different one. These should not require you to have a login for what we're asking for, but if you do create a login and you do create an account, there is increased functionality. So I'll give everyone until I see the phones go down. And once you're there, I want you to ask whatever you're using to create a kidney-friendly recipe based off of the last thing you remember eating. And I'll share my results. Does anyone have results yet? Do you like the results? All right, so I will share what I got. So I said, this is how I crafted my prompt, is I'm a dialysis nutritionist, which I'm not. Your patient is having trouble controlling your potassium and phosphorus. Can you please come up with a rice dish that is low in potassium and phosphorus? And it came up with herbed lemon rice with garlic and bell peppers. So if anyone wants to share what they had, I'm happy to, you can shout it out or share with us. Yeah. A lobster roll. All right, what else?
I asked for a kidney-friendly gelato recipe, which apparently incorporates cream and almond.
Oh, okay. All right. All right. There we go. I like that they're very Boston. So I would say some.
Mine's for kidney-friendly baked fries.
Oh, baked.
Fries, French fries, and they talk about the double boiled.
Oh, that's really nice. So tips that I suggest as you do building these prompts is be clear and specific. If you just say kidney friendly, it may not be as useful as if you specify like you're a nutritionist and you're trying to come up with things for people, to provide the context and then also give the format and tone. And then you can always go back and say like, well, let me change things. So why don't we keep that up and change it? So let's change it, to a specific type of cuisine. My parents are Chinese, I am American-born Chinese, so I eat a lot of Chinese food. So I would ask them to create it into a Chinese food. So you don't even have to retype your original prompt. You could just ask, can you make it a Chinese dish? And it will change it to fried rice. You could do it for whatever your population you treat, but it's kind of helpful that way. And then I also did a more fun one. If you're a pediatrics and you want to make it cute, you can say a Chinese dish, but also make it Mickey Mouse. So it even gave you a nice picture. So. Did anyone's change in an interesting way or unexpected way?
My original prompt I said it needed to be simple.
Okay.
It was biscuits, so it said use canned biscuits. So then I said it needs to be lower phosphorus. So I did a very simple recipe for homemade biscuits.
Oh, fancy. Yeah.
I'm still on my original one too, and I just put in kidney-friendly pancakes. It gave me 4 links to recipes, and then said these recipes are all low in potassium and phosphorus.
There you go.
Which, just saying a kidney-friendly pancake, that's impressive.
I would say that actually brings me to my next point, which next slide. But my first slide is general precautions about this use. Is if you're using ChatGPT, note that everything you're typing in is going into their cloud server, and they're using it to train and improve their model. So you can elect not to improve it for everyone, and that's just a setting in your ChatGPT data controls. And I think it's similar for all of the other ones too. But even with that, this data still is getting processed by the cloud. So do not put any PHI or any sensitive information into this. Even with writing like letters of recommendation, you have to be a little bit cautious with what you're putting in, because some people may have personal statements or CVs and really sensitive stuff that you don't want to put out there. My next one was about hallucinations. So I'm really curious if actually those 4 links really work. Because what hallucinations are is that they're false or misleading, doesn't make sense. It's actually just a lie, makes up resource references and citations. And the current versions are a lot better, and I've tried to make it a hallucination and have been unsuccessful. But here's an example that I could give a shout out to my colleague, Dr. Stacey Leisman. So she was trying to figure out what the difference between a sauce and a dressing is. And according to Google's Gemini, a sauce adds flavor and texture while dressings are used to protect wounds. So, and there's even a picture, and it's still not the right thing. So how can you reduce hallucinations? Really make sure you're fact checking everything. Don't take it to be the truth. These models are trained on all the information on the internet, and some of that information is not necessarily truthful or is biased against certain groups or certain people. When you write your prompt, you can specify that you want sources so that you can fact check for yourself. Human oversight is key, and then there's these newer models which use RAG, which means that it's specifically referencing a reference. So for example, if you're looking for new treatments in CKD, you can specify, I want to look at these KDIGO guidelines and specifically reference that. Some additional concerns, this is my last slide, is about the transparency and explainability. So as you know, you're putting things in, but you don't actually know how it's generating this language and these responses for you. So that's why there's a lot of things called black boxes. And because we can't see behind what's happening behind the website, that we may not always trust it because we like to know why, right? A lot of these models are built on electronic health records data, so patients have consented to use EHR for their clinical care, not necessarily for research purposes, so they need to be informed with how we're using their data and being consent to have these technologies be used. And just make sure that if you actually look at where all of the AI and ML research is coming out of, it's going to be China, America, UK, Korea. So it's not everywhere, and so that means that there's data. There's data that's not getting used by a lot of people in the world, and that when we develop these really good resources, they're not getting deployed to these people also. So making sure that we get equitable access, good models, and then getting it out there. So with that, I will hand it over to Dr. Tangri.
Thank you, Dr. Chan. That was incredibly informative, very complex topics in a very fun way. So next I'll welcome Dr. Navdeep Tangri. He's an associate professor in the Division of Nephrology and Department of Medicine at the University of Manitoba. Dr. Tangri's research program is clinical and translational and focused on improving clinical decision-making for patients with advanced chronic kidney disease. And he's really world-renowned for his work developing and validating the kidney failure risk equation, which is the gold standard to predict the need for dialysis in patients with CKD. He's also the global PI of the VALOR CKD study and leads a lot of patient and cluster randomized trials. So welcome, Dr. Tangri.
Thank you. It's really a pleasure to be here, and thank you for the committee for considering this presentation. I thought the last half an hour was really excellent. It covered, we decided to split the talks, as Lily mentioned, into generative and predictive. So I'm being tasked to talk about machine learning and predictive artificial intelligence. And I think it's important for all of us, starting from the people who are going to develop these models, going down to you being asked sometimes to do peer reviews of this type of work, and finally you being asked to use them in your clinical practice, that we learn about critical appraisal and how we can actually make informed decision and not get dazzled by the machine. So these are my disclosures. So my objectives are to identify applications of supervised machine learning in key clinical areas in nephrology. When I'm talking about supervised learning, what I'm talking about is you know what the label is. You know that the patient had a hospitalization, had kidney failure, had mortality, and you're able to label that case, and then you're asking a machine to learn based on your label. You're supervising, and that's mostly what I'm going to talk about. There are other areas which were completely unsupervised, where you just give a machine data and you ask it to find patterns and clusters. I think that's less useful personally, so I'm going to focus on supervised, which is the majority of the work that we do. I'll talk a little bit about machine learning tools currently in development and commercial use that can impact clinical practice. And I like to orient all of us in sort of a nephrology first way and machine learning methods second. Methods come second to the clinical use cases. So when I speak about ML or AI, I'm going to talk about what's the use in transplant? What's the use in AKI? What's the use in CKD? More than methods per se. And then very important to still discuss, just because you own a hammer, everything is not a nail. What's the best use case for machine learning? In what types of scenarios is a regression model equally helpful or better? So I'll try to cover some of that as well. I'm going to skip most of this slide because this was well explained previously, but machine learning is a subset of overall artificial intelligence. Deep learning is a subset of machine learning, and generative AI is part of NLP, which is a subset of deep learning. So getting right to the clinical orientation. Let's talk a little bit about predicting inpatient acute kidney injury. Let's talk about biopsy classification, where there are examples of deep learning, rules-based classification, natural language processing. Talk about intradialytic hypotension, so that's dialysis. So we've got AKI, transplant, dialysis, and some of our work on predicting CKD progression. So most current applications of artificial intelligence in the clinic today, in your life today, it's generative artificial intelligence. That's kind of what you're interacting with all the time. But in the clinical setting, in the device, like if you think about the regulated clinical setting in particular, it's medical devices, it's machine learning, it's not generative AI. And machine learning roughly could be divided into supervised, unsupervised, or reinforcement learning. Reinforcement learning is just playing chess, basically. You do a move, the computer does a move, the computer is losing, it'll learn, and that sort of reward and penalties, carrot and stick thing. Mostly supervised learning, so focus on that red part, classification and regression. You have traditional regression, you have tree-based methods, deep learning, and supervised support vector machines. So again, label data, direct feedback, output prediction. That's the vast majority of what you'll see, that one side of it. And the other sides are no label, no target, no feedback, clustering of complex data, or a decision process with reward. So whenever I get to a question in prediction, this comes up all the time in our lab, and the first question I always ask, do I need the hammer, right? Do I need machine learning to solve this problem? And what I think about is, first of all, smaller data sets versus larger data sets. Perhaps I need an advanced analytical technique if there's a larger data set, but not so much larger in the number of rows, probably larger in the number of columns. Okay, so the more columns, the more multimodal data you have, you may get more benefit or more bang for your buck with a machine than a regression method. So there is issues about usability. So I think regression techniques still are easily deployed in clinical applications. I mean, you can essentially create an Excel spreadsheet from a regression model and use it at the bedside, whereas a machine model requires more back-end computation. There's interpretation difficulty. Every machine model you could make, you can spit out variable importance, but it's not the same as variable importance from a regression. It's not as intuitive. Training time, I think, is less important these days because the hardware is so good. But ultimately, often my decision will come down to the type of input data. The moment you step into audio, image, free text, you're really stepping into machines. Whereas if you're talking about claims, comorbid conditions, demographics, labs, probably regression is good enough or just as good. Then I think you still very much start from the clinical problem. You have to understand the clinical problem deeply, then transform it into a machine learning problem, do data collection, integration, cleaning, feature engineering, model training, parameter tuning. These are things that are more unique to machines, less unique to regression. With regression, you're kind of, looking at the main effects, then trying to find an interaction if there's an interaction. And then you're generating predictions, both in regression or machines. But with machines, you should you may have to do some monitoring and debugging. There may be drift if you're retraining and trying to iterate on your model. And ultimately, I think you have to go back again to the clinic. Does the model meet my clinical needs? And if it's not meeting, you have to restart again. So the purpose of this slide, again, is to emphasize the point that the problem has to start in the clinic, and the model you make has to solve a clinical problem. So let's take two examples. So first, a prediction of AKI in patients undergoing cardiac surgery. This is data from the Cleveland Clinic. Looking at the first post-operative metabolic panel. So I'm a lab person. I love models that use lab data. So if you use creatinine, BUN, sodium, bicarbonate, albumin, and potassium from the very first metabolic panel, you can predict AKI within 72 hours or 14 days with logistic regression. Okay? 6 variables, all highly structured labs. You do not need a machine. Highly explainable. I can tell you which variable was the most important, which variable was the least important, and how important they were one to another. Because to me, the reason that's the case actually comes down to the clinical problem. This is a really discrete insult. It's cardiac surgery. You know when the insult happens. You have the very first panel. There's far fewer things impacting it. Okay? So now let's look at a more complex scenario. Prediction of acute kidney injury in all-cause hospitalized adults. Now here, it could happen from volume contraction, it could happen from acute interstitial nephropathy, it could happen from ATN, there could be a GN brewing. So there's a 59 variable model. It uses demographic characteristics, vital signs, chemistry, hematology, trends in vital signs and labs, and nursing documentation. So you're sort of firmly in machine territory because you're using multiple domains of data and you're trying to solve a more complex problem. But what's common is there's external validation, there's development in one cohort, external validation in an independent cohort, and you're talking about the very same things, AUC, calibration, sensitivity, specificity. So how you evaluate a machine learning model compared to a regression model, you should look at them with the same rigor, and they have to demonstrate the same ability to discriminate, to calibrate, to perform. There's nothing special about one or the other that should give something a free pass. So now I would say, we started out with hospitalized patient. Probably the perfect case for deep learning or machine learning is kidney biopsies, right? Pathology and radiology probably together is where deep learning and machine learning has really thrived. If you look at medical devices that use machine learning that are approved by the FDA, I think about 80% of them are in radiology. There's another 10% in cardiology, but they're largely image-based as well. They're sort of echo or EKG-based. So wherever there's images, deep learning is going to do a lot better than regression, right? And you can actually identify changes on slides that a human can't see. You can integrate clinical and pathological data. We at our center use natural language processing to create a biopsy-based registry. We took 2,000 plus biopsy reports and converted them to highly structured data and linked it to medications, claims, long-term GFR, ACR. And it's just such a great use case for that type of work. There's this nice paper in Nature Medicine looking at a rules-based classification, even trying to take the biopsy report, applying a set of rules, doing an automation of the Banff classification. And what they found was whenever there was a change in classification from the machine, the prognosis was worse. So even simple rules-based ML approaches can be helpful in these types of cases. More deep learning data on kidney biopsy, so you can quantify interstitial fibrosis better than a human. There's a nice paper recently from colleagues of mine in Toronto who are getting fibrosis from an ultrasound image, something called H-scan. So they're just putting an ultrasound probe on an allograft, and they're able to quantify fibrosis quite well, and they're predicting better than sort of eGFR at 1 year out. And there's, of course, MRI elastography as well. So again, imaging is a very nice application where, our eyes are only so good, so we can pick up more patterns using a machine. And this is data from the H-scan, as I mentioned, takes 5 minutes, inexperienced operators, estimating fibrosis in renal allografts, and more strongly associated with eGFR compared to the biopsy report. Because the biopsy report is sort of the human eye telling you. So again, I don't think the H-scan replaces the biopsy report, but an H-scan can come at the bottom of the report. So, IFTA 26 to 50%, H-scan X, right? Even if you think about how many reports you've read where IFTA is 26 to 50%, that's a very big range. Could be 49, could be 27, right? So here you can generate a number that can give you more precision. Now, what about CKD and dialysis? So starting with dialysis, this is a random forest model done at the University of Ottawa. And what they really did is they looked at trends in lab values. And unplanned dialysis is a big topic with the CKCC, KCF care models. You want to prevent unplanned dialysis. It's extremely costly. And what they did is they said, what are the variables in the, that are important? Chemistry, CBC. But let's look at the variables at a single time point and all trends, use a random forest, and we can predict kidney failure and unplanned dialysis. And again, what's common? Predict discrimination and calibration, and external validation, right? So machine learning tool, regression tool, same metrics. This is data from Fresenius looking at real-time prediction of intradialytic hypotension. Very useful, taking data from dialysis runs. We do want to prevent intradialytic hypotension. It's a cause of morbidity in the unit. And here you have an AUC. You can show where you can set a threshold, what events can be predicted, and it also shows you what's predicting. So trying to give you some sense of explainability. The way this works is you pick a threshold. So you say, if it's more than 15% probability of intradialytic hypotension in the next half an hour, I'm going to ping you, right? So what do physicians hate? Alarms, alert fatigue in the AHR, right? So you have to set this right. So intentionally, I would pick 15% because you want 95% specificity, right? You want, it's okay to have 50% sensitivity, but when you alarm someone, you want to make sure that you're only alarming them with specifically. So you can get 797 out of 1,400 correctly predicted sessions with intradialytic hypotension. So it's quite good. If you know half an hour before it's going to happen, maybe you'll turn the UF rate down. Maybe you'll do a couple of other things, and you can make a difference in the patient's life and their symptoms. Okay, so that's we've covered AKI, we've covered transplant, we've covered dialysis. So let's go to CKD. So my favorite topic is intervening early, right? We have to intervene early to slow CKD progression, and people with an eGFR of greater than 45 are invisible, right? Nobody sees them, especially if their eGFR is greater than 60. Oh, they don't even have a disease, because we only think in one dimension, right? So I'm a firm believer that identifying patients early and treating them early slows CKD progression. And what's been missing is a way to identify these patients much earlier in their journey. So we developed these new models that are working in people with all stages of kidney disease, including people who don't yet have kidney disease today. And they predict 40% decline in GFR or dialysis. So 40% decline is really great because it works if your GFR is 100, and it also works if your GFR is 30. It's meaningful at all levels. And we like to use, in my lab, routinely collected lab data, because we think lab data is highly structured, and models that use lab data can be used in Asia, in Africa, in North America, in South America. They can be used everywhere a standard lab exists. So we're really very implementation focused. So we started out in our province where we had lab data on 1.2 million people. We had every claimed drug lab test encounter captured. We found 77,000 people who had a CBC, a metabolic panel, and an ACR in the last 12 months. And now we've validated in 5.8 million US adults a model that's a random forest survival model. So these are some of the validation data sets. I'll skip some of that. But very similar thoughts, right? AUC of 0.84 to 0.88, highly accurate models, really well calibrated, and finding 87% of progression events that occur within 2 years and 77% of events that occur within 5 years. So whether you use machine learning or not, you have to build accurate models, externally validate them, show that using a model improves clinical outcomes, and then kind of get them into clinical practice and implementation. The steps do not change whether you use regression or machines. So we worked on this. We showed not only in this 4.6 million person data set with Anthem and Elevance, we showed that our model was still equally accurate, but actually people who were high risk were also very high cost. So 3 to 5 times per month all-cost care, 13 to 30 times CKD-related costs, 5 to 10 times more inpatient visits and ER visits. We followed that up with a clinical utility study where we showed that if you show a physician a high-risk patient, they tend to improve the quality of care dramatically. They're more likely to prescribe RAS inhibitors, SGLT2 inhibitors, finerenone. They're more likely to test for albuminuria. So all of this is meant to still follow the same evidence paradigm, regardless of the methodology used. There's other good work done in this area. This is a machine learning model developed by Sonic Labs. This predicts 30% decline. I would say the only limitation of this model is it relies on historical EGFR slope. And historical EGFR slope, in my experience, is not reliable unless you have 5 to 7 data points over a 2-year horizon. So if you have a slope that's built on 2 data points over a year, it's virtually noise. It's completely meaningless. And it's very difficult to assure that a patient will have 5 to 7 data points over 2 years of history to have a slope available. This is work led by Lilly, combining AI and biomarkers for chronic kidney disease, the KidneyIntelX model. And again, this is a regulated product, so gone through the rigor of testing and validation and regulatory clearance. And this uses biomarkers as well as physical function characteristics as well as labs. This is a data visualization developed at Wake Forest in Indiana. This combines machine learning models, EHR data, looks at trajectories, tries to show markers and predictors all in a giant dashboard that's visible attached to the EHR. So you can go from the EHR, you can go to this dashboard. And the inputs are sort of everything. They're using lab data, 15 features, kind of like us. And then they're using vitals, demographics, and showing like an example of showing you that this patient, 42747, is going to have a poor trajectory. So the reason I bring this particular case out is because it applies some of the methods that are common to all of us, use of lab data, implementation, trying to get into clinical utility, and they've managed to put this into a health system. Because this is really where all of these tools need to go, whether they're machine learning or regression-based. Ultimately, the rubber has to meet the road in implementation. And there'll be many tools that you'll be exposed to and you'll be asked to adopt. But I think the winners will be the ones that are most implementable. So if you're developing something, focus on implementation, focus on your end user. I think accuracy will get there. You can get to accuracy in a number of different ways, but implementation is probably more important. So that's my last slide. Okay, so I think both my co-speaker and I would let you know that AI/ML has arrived. I mean, it's a part of our everyday life. To me, the availability of high-dimensional data with advances in computing make this highly feasible. So I've been doing this for a very long time, meaning nephrology and science, not generative AI. But I did write my very first paper in 2006, and it was on a neural net to predict PD survival. So this technology has actually been around for a very long time, but computing today has made it much more highly accessible. And so now you can essentially, a phone today is more powerful than the computer we built a neural net on in 2006. So you can run even a large language model from your laptop from start to finish. So that's really what's truly changed. And I think high-dimensional data in kidney disease can come from the lab, it can come from the EHR, it can come from radiology and pathology. And from a machine learning perspective, to me, a slam dunk use case is when imaging data is required, a large number of columns are needed or a large number of features. And this last bit, when prediction is more important than explainability. Remember, there are different reasons for building a model, okay? Sometimes you build a model because you want to learn the relationships between the predictors and the outcomes. And there you are probably not wise to use a machine. And sometimes you build a model because you want to get the best possible prediction of the outcome, okay? So to give you the simplest example, if you were building a model to predict fatty liver, right, you could either like measure fat in the liver, or you could use a surrogate like the AST to ALT ratio, let's say, or the FIB4 score or something like that, right? If that gets you 90% of the way to the gold standard, but is much more easy to measure, that's what you should use. And even if the variable you're using doesn't have biological relationship to the prediction, in prediction, that doesn't matter. You just want to generate the best prediction. And the last message is that it all only works when it's integrated into clinical workflow. Nothing works without integration into clinical workflow. No one will use your tool if they have to step outside and go to different screens and different portals and do all sorts of things. So as you're out there, insist on evidence. Encourage developers to improve scientific quality and transparency. Get IT vendors, the machine learning, the AI vendors that are going to come to your door. Tell them to show me the science, show me the publication. Critically evaluate the solutions that are presented to you. Don't accept flash. Don't expect to accept a lower degree of evidence for an ML model that you wouldn't accept for a regression model. And the ASN position on AI in kidney health is that AI is a tool in your toolkit. It's not your replacement. We want to encourage physician-led solutions, and we want to work with regulators and industry to ensure that nephrology needs are addressed, and that nephrology is kind of working with, traveling with, and leading the revolution in medicine. Thank you so much. We're happy to take questions together.
Great talks. Srinivas from Novartis. So one thing I'm saying is that it's great, right? So we have NLP, we can extract information, we can build prediction models. Great for CKD, where you're trying to plot trajectories as to when to start initiating treatment for dialysis, start dialysis, refer to transplant, prevent crashes. We stand at a time where we should be thinking about eliminating CKD and guiding physicians towards earlier action when they see proteinuria at earlier levels, a plethora of therapies that are available, which are confusing. So I would gently suggest that the focus should be on next best action as opposed to prediction, because patients don't come for a prognosis and tell them when they're going to crash. They want you to prevent them from crashing. They want you to actually take care of them in the present and make the best diagnoses. Where do you see that going?
Yeah, so I totally agree. I think that it's really important that you think of the entire workflow from end to end. And the last piece so to take your example exactly of earlier, eliminating CKD, basically there's three things that need to go right for the patient to have the right care. First, the patient needs to have the right tests ordered, right? So if you just order a creatinine and you don't order an albuminuria, you miss early CKD, right? You just miss it completely. Next, you need to interpret the tests appropriately. So a big thing that happens is that the albuminuria is slightly elevated, but because the creatinine is normal or the eGFR is normal, it's dismissed, right? And the third thing that happens is that even if the albuminuria is interpreted as abnormal, the person doesn't get the right course of action or the right treatment. Maybe they just get a RAS inhibitor and that's what happens. Or they don't get investigations. If they have proteinuria and hematuria, they don't get referred for a biopsy. So as we're developing a solution, you have to think, is my solution going to bridge all three gaps and combine prediction with clinical decision support? So I think we're there for chronic kidney disease, like general CKD. I think there's a different set of workflows for more specific diseases. The prediction may be the same, but the best decision workflow might be different. But it almost always has to tie in all together for it to really work and have an impact.
Thank you. That's what I wanted everybody to hear from you.
I think there's also a lot of innovation that can come to address some of those gaps. So I went to a talk this morning about nutrition, and they're saying that we don't have enough nutritionists, right? And especially in early CKD, when we want to guide people, and a lot of what we talked about today with generative AI can actually help people get access to that. It is also available in different languages, so you don't necessarily have to be a translator. They can also, it reads for you, so for people who have potentially lower literacy in general, that they can actually just talk to these things instead of having to find a nutritionist, get that person an appointment, get it funded by insurance. So these are kind of these gaps that people can readily now have access to without having to use insurance for. And I think there's also a lot of underdiagnosis in general, which AI can also help with. And then I think clinical decision support is going to be really important here too. So.
Hi. We depend a lot on guidelines with hypertension, glomerular disease. So people like myself not as familiar with AI, are we going to anticipate in the future with the explosion of different options, are there going to be expert opinion on which AI to use? Or are we going to end up being at the mercy of whatever practice we're working at picks that AI, and maybe we're not familiar if another one's better or not?
An ASN task force.
Yeah. So I think the ASN task force is thinking about some of these things. What we want to be able to tell you is how to evaluate these solutions. But as you can imagine, a society is unable to endorse or not endorse a solution. At the same time, we can also tell the industry, so the software industry in this case, what ASN members need, or what nephrologists need. So the idea is that you get them to build tools that actually will help our clinical care, and then we tell you how to critically evaluate those tools. I think that's sort of what we can try to achieve. Yeah.
I think one other thing is that a lot of these models that are through industry and companies are not necessarily transparent. So I was just talking to a colleague, and I don't know if anyone went to I think it's DeLorean AI group, and they're basically doing like different risk prediction models for people who have end-stage kidney disease on dialysis. And they had a whole presentation to these people, and then I was like, oh, well, what was their training data from? And they had no idea. Like, not the DeLorean folks, it was the middle person that I was talking to. So I think it's also really important to train you to know what questions to be asking these folks, so that we know, we can hold them accountable for what their product is. That is the also interest of a lot of different academic institutions now to actually develop these AI education programs. They're in the pipeline, they're not there
Just
yet, but
answer
they are.
that. I think fellowships in nephrology are suffering. So if you actually think about it as a situation where you tell people you're teaching them about design thinking, implementation, population health, that's how the nephrology workforce is going to be reinvented, so that you're in a position to actually populate the leadership of institutions so that you can re-engage and make the society what it should be.
It's in the works, at least at our institution. A lot of it is still coming online, though.
Are there any other questions? Okay, well, I think we can speak for the whole audience that we're glad that we stayed until the end. So thank you, and please join me in thanking both of our speakers.